Now, in an effort to make things easy as possible for us in the post-acute world, when we reach any kind of a critical junction, patients going bad or having problems, we don't have clear orders to guide us through or access to an RT or to a physician immediately at 2 a.m. We've developed 3 primary protocols for you. An oxygen protocol, bronchodilator protocol, and a bronchial hygiene protocol. The idea is to give you a decision tree to go through to allow you to very objectively measure your situation by how the patient presents and to guide you through a series of decisions to hopefully address the issues. Now, I'd like to tell you today to use these right now, but I can't because they haven't been approved yet. I will find out from Susan tomorrow, who's here, when clinical is going to review them. Hopefully it'll be part of your order set moving forward in the future. But right now, that's not the case. I have submitted this along with new policies and procedures to get this approved. But let's go to the first one, Bronchodilator Protocol. Excuse me, actually your oxygen protocol is the first one. So the goal would be to have a patient comes into the building, that the standard order set would have an oxygen protocol ordered, so the patient had any issues come up, you'd be able to go through this decision tree to guide you through applying oxygen appropriately. So again, looking for indications beyond the doctor's order. SATs drop less than 90. Second, in an emergency situation, the patient may be exacerbating or hypoxemia is suspected. Trauma, patient falls, maybe bleeding out. Suspected cardiac event, you think the patient's having an MI. They're complaining of chest pain, jaw pain, or left arm pain. Or again, short-term therapy due to an exacerbation. Let's say patients, remember our patients we talked about earlier that have, again, that bronchitic, that asthma component kick in, and not breathing well, and their SATs are being impacted by it. Maybe a short-term fix to get their SATs stabilized, resolve the dyspnea. So then you see that indicator, move down the decision tree. The answer is, again, short-term therapy or surgical intervention. A possible complication, again, yes or no, and then move down the tree accordingly. So again, the idea is go down the tree, answer the question subjectively, and then take the next step. Now again, until you get a physician order to these approved protocols, use these as guidelines for you professionally. So if it was me, I'd review them, learn them, to give you suggestions if the doctor's not available, to follow, to get approval for, or to make suggestions. But these are all based on the American Association of Respiratory Care guidelines, clinical guidelines. I'm going to turn the page to the Bronchodilator Protocol, same thing. Without an order for a Bronchodilator Protocol, we look for indicators. Again, complaints of dyspnea, audible wheezing, hyperinflation, hyperventilation, reduction in airflow. Then again, take the next steps, ask the question. Is there a contraindication or a potential risk in initiating therapy? Yes or no? Then take the next step down. Then you have to decide, again, what delivery component is appropriate. And then you can make suggestions based on that tree, what medications you may want to suggest to the physician. So again, follow the decision tree till you find again the right answer that allows you to present again an optimal therapy to the patient to resolve the condition he's in. Let's go to the Bronco Hygiene Protocol. Next one. So without an order for bronchial hygiene, what's the indicators? Difficulty in mobilizing secretions effectively. Evidence of retaining secretions. Evidence of atelectasis. And do anybody know the definition of atelectasis?
Yeah, for the lungs.
Yeah, but what's the definition? It's the absence of air. atelectasis. It's the absence of air. So if you look at a chest x-ray, you see a whiteout. As an example, it's the absence of air in that lung field. Atelectasis is the absence of air. So again, if you're looking at a chest x-ray report, again, most patients today that have pulmonary compromise in the hospital are discharged with a discharge x-ray. So again, go back to your reports. Then compare that to actually your physical assessment. Do you hear breath sounds or not? Go back, you look at your last chest x-ray and it indicates atelectasis, the absence of air in the lung field. That could be an indicator for, again, bronchial hygiene therapy.
Kathy, did they say anything to you about ARDS when you were in, or no? No?
No. When I went in, they were very hesitant about putting me on the high flow oxygen.
Right.
But then Dr. Bagmurray, he come in and he said that they were going to give me the COVID medication, and it starts with an R, and I can't. Yeah. And he said, but they don't usually give it to awake patients; they give it to vent patients.
Right.
But it was a 5-day series that they give it to me, and it kind of helped.
Right.
So, but ARDS, no, they didn't say anything.
So ARDS is adult respiratory distress symptoms. Syndrome. I know you guys have heard a bunch about it because of COVID. So before COVID came along, ARDS was not really uncommon. Typically, patients that got it in the ICU, they would be shipped out to an LTAC, and our mission would be to get them out. So when you look at it, or get them through their ARDS episodes, so when you look at a typical ARDS MRI, and Mike's mentioned whited out frequently is what made me think about it, normal ARDS before COVID was 30 to 40% whiteout. And like I say, that was not uncommon in the LTAC environment. So I have been able to see several MRIs from COVID patients. And it's like 85 to 95% whiteout. You really had to hunt to see black. Black is there in the COVID patients. So that's why there was so much of a difficulty in ventilating them originally up in New York, because we have what's called the ARDS-NET protocol, which, just like probably every other disciplines that you guys have, you've got parameters to follow and what you're going to do and what you're not going to do, and this, that, and the other. And so when they were trying to apply those protocols to COVID patients, the outcomes were not nearly as well, simply because the ARDS was that much more severe.
So to say the least, some of these protocols are going to be updated significantly with COVID, in the last year, because these protocols were written pre-COVID and for a very different kind of patient. Now again, but to Ray's point again, we've seen a lot of comorbidities now that have really impacted how COVID impacts patients and their progress. ARDS is one of those things that now is even more prevalent now than it was pre-COVID. You see a lot more of it now. So that's one of the reasons why it led to the prone positioning to recruit lung. Again. So, again.
It sure helped me.
Well,
It's common practice now.
Right.
It wasn't something that was done very frequently. It was used occasionally on severe situations, but not nearly pre-COVID was it used like it is now.
Yeah.
5 minutes.
But the last thing we'll flip over is oxygen weaning guidelines. It frustrated me back in the day, early days post-acute, doctor come in and write orders for weaning for the nursing staff, and they just shrug their shoulders, don't know what we're doing. So again, the weaning guidelines should give you a baseline to start from. So the doctor was writing order for oxygen weaning, which this has not been approved yet either, but I'm hoping to get it all approved here soon. So by the time we get the program implemented, hopefully all these will be approved and be part of a standard order set if the doctor comes in. But the idea is to give you a starting point and give you details around how to document And again, how to take a patient from, again, the original order when they came in. It says an example of 5 liters or 4 liters or 2 liters down to 2 liters or the room air. You want to document how to progressively, incrementally decrease that oxygen flow rate and delivery. And then even change the delivery device to get a lower delivery component again, and document it appropriately, and again, successfully wean the patient. Again, to get them down to room air to a lower flow rate or FiO2 requirement in the facility or prior to going home. So with these protocols and guidelines, I would advise you to read them. They're not approved yet. Become familiar with them. And if nothing else, use them objectively in your own work to make suggestions, and to, again, when you talk to the doctor, to help guide them if they're unsure about how to proceed in certain aspects of routine care, like with bronchial hygiene, what's appropriate. Doc, hey, maybe we use an acapella so the patient can manage himself. Maybe we get PT to come back and, again, do some postural drainage, some light percussion 2 times a day. So things that keep these in mind. Hopefully, I'll know more tomorrow about when I can get these approved, so they're part of the standard order set moving forward for pulmonary patients coming in. But I can tell you that based on the standards they're written on, American Association of Respiratory Care, these are sound guidelines to follow. So please feel free to review them and apply them to your professional practice on your own. And I think it'll help you think a little bit more critically and objectively in your patient care, and make suggestions interacting with the physician and your RT coming forward. Any questions, anything we covered today?
Anybody that's worked in an ICU unit is going to feel like they might be back in the ICU unit once you start having your ID interdisciplinary meetings, because all of a sudden it's not just nursing, and it's not just PT, it's not just OT. When you start getting these patients, it's everybody's. Yeah.
Just a question. So when we're talking to these patients, how many are we allowed to have per facility? I'm sorry. When we start getting these patients, how many are we allowed to have per facility?
So the maximum is 20. That's all we're certified for. But again, we take a look at staffing, and obviously acuity is a part of that. So we'll be cognizant of that too. So we want to make sure we do the right thing.
Well, let's clarify our question again. Again, you weren't talking vent patients. You were talking about complex pulmonary, right?
Yeah.
Right.
Yeah.
Oh, I thought you were talking about vent. I'm sorry. Vent.
Okay.
That's we can do that in the whole building. We're not going to have 99 of them, but you know what I mean. It's just going to be based on case by case. In your building in particular, Pickerington, right? You're at Pickerington.
We have trades. We don't have anybody on the bed.
Yeah, not yet. Yeah, your building will have.
And then you're going to have the pulmonary rehab program, right? Outpatient, so that's going to bring in additional patients, but they're not going to be residents.
So we're going to take a look at, we have a meeting specific for Pickerington and then an offshoot for Logan with the Mount Carmel systems. And we're actually going to be talking to them about the unit so that we can get some feedback from them, what they think, the types of patients they would refer, what the need is today, other than COVID. So that conversation is in process as well.
So is it just Mount Carmel that you're working with, or is it Ohio Health?
All of them, but I'll tell you, Mount Carmel's the easiest to work with. OSU is not. Because they think OSU is its own world. And then Ohio Health, we're trying to get working. So if you have any connections, let me know.
Okay.
And keep in mind, we just go say COVID impacts everything right now. So again, today, everything we've covered, you've got, I don't know if you have any trach patients today in the building, but again, everybody that we've talked about today, you've got patients here already. So again, you got a trach patient in the building today?
Then we got one.
Yeah, but every place has COPD.
Right, everybody has COPD patients. Everybody has patients that have impaired mobility. Everybody has post-stroke patients. Everybody has COPD patients. So again, everything we talk about today impacts you today. When you leave this room today, if you're going on the shift to work, you're going to see these patients we talked about today. So don't think that this is all brand new to you, because it really isn't. The embassy wants you to see holistically everything you've got in the building today and moving forward. Make you better prepared to take care of patients you already have in-house, keep them in-house, not go back out to the hospital. Additionally, prepare you for the complex patients that are out there now that can be placed. So again, you already have a lot of these patients in there. You already have a lot of the employees here that have had COVID. So again, that's me as well. So COVID and paralysis. So again, I'm doubly blessed. So again, so don't think about moving forward, you're going to see this huge complexity of patients and lots of high census with lots of needs. The idea is you already have patients like this already today, so these things we've talked about, put in practice immediately as you go out treating patients today. Don't think it's just what's coming tomorrow. These are patients that you have today already. Does that make sense?
Yeah.
Yeah.
There was just a post, I don't know how many folks on here go through LinkedIn. There was a post earlier this morning from a nurse out west, and it made me think of you, Kathy. 1 year today, she's post-COVID. She was perfectly healthy prior to that, no medical issues of any sort. Now she has high blood pressure, type 2 diabetes. Oh gosh, and there was one other thing.
Probably renal issues.
Huh?
Probably if it's someone already, renal issues.
Okay, so there's no telling what the future holds for all these folks. I was curious, have you sensed anything
I was type 2 diabetic before I got
beforehand? Yeah, but
But other than that, no.
Okay.
I mean, nothing's changed.
Yeah, it was interesting. In the early days of COVID, they found a huge correlation in 3 areas, as Ray mentioned. Patients with hypertension, patients with, renal issues, and patients that were diabetics. For some reason, those 3 categories. But again, those 3 categories usually have other comorbidities as well related to them, like your COPD patients, that are in poor health already. So again, just again, we talked about this before when we had our first meeting with Embassy. Comorbidities matter. We're finding that out. So again, COVID just complicates people that already have multi-system issues. So.
Yeah, when they say that all these people have died from COVID, what were the underlying?
Correct. All COVID
Right.
did was exacerbate those underlying issues to the point of, we had a friend of ours we notified of yesterday that they said died of COVID, and I knew the lady, she's a good friend of ours, and the lady she was a train wreck before COVID. COVID just helped move those things along.
and you get a bigger reimbursement.
Yeah.
Right.
Yeah.
That's it.
exactly
Yeah.